really lucky today. We have Dr. Gabriel Dery with us, and he's going to talk about what we need to know about our eyes, particularly at this stage in life. And he's going to make us aware of eye diseases and other such things, and eye care, I imagine. He was professionally credentialed in France, Canada, and the USA, specializing in corneal disease. He practiced in Beverly Hills and South Orange County, California for 45 years. At the invitation of the Republic of China in 2006, he served 2 years at Tianjin, I may be bastardizing that, Medical University, teaching, lecturing, and treating patients. He was also a World Health Volunteer, flying monthly to Guaymas, Mexico to treat villagers. Please welcome Dr. Dery.
Thank you very much. Before starting, I'd like to give a little doctor's joke. Dr. Bensman, it's not for you. Imagine in a small village, an elderly doctor, Dr. Spike, has been practicing for many, many years to the villagers, and he was doing quite well until a young doctor came in and said, I'm going to establish myself and replace this old doctor. So the old doctor, losing patient, put an advertising in a newspaper and said, I cure everybody, I treat everything, and I can help you with any problem you have. If I cannot do it, I will give you $1,000. The young doctor goes to see this older doctor as a patient and says, you know, Dr. Spike, I lost my taste. I cannot taste anything anymore. So Dr. Spike goes in the back and brings a glass full of gasoline. And he gives it to him and he says, try this. So he drinks the gasoline and says, oh my God, this is gasoline. He said, you see, you just recovered your test, $500. So the young doctor is upset, goes back home and comes back a week later. He said, I need to get this doctor. So the next week he comes in, he says, you know, Dr. Spike, I think I lost my memory. Oh, well, that's not a problem. We can fix that. He goes back and he brings a sand glass of gasoline. And he gives it to him and he says, but you gave it to me last week. Oh, you just recovered your memory, $500. So he pays again, and this time he said, I need to get this doctor. So he goes back again a week later and says, what's the next step? Vision. Oh, yeah. Thank you. And he goes back again and he said to the doctor, he said, doctor, I lost my vision. I cannot see anymore. Oh, no problem. You know what? I cannot help you. I'm sorry. I need to give you $1,000. So he goes back and he brings a bill of $10. And he gives it to the doctor. The doctor looks at it and he says, it's only $10. You just recovered your vision. $500. Without further ado, I'm going to be talking tonight. Can you hear me okay?
Yes.
Okay. It's what you need to know about your eyes. And it's a complicated lecture, it's very long. I'm going to try to go as fast as I can. I will start first this lecture by telling you the refractive error, which means why do we wear glasses, why people are nearsighted, farsighted, whatever, and I will give you this information right now. First, I want to show you a schematic eye. And I want you to pay attention to what I want to tell you right now, because the whole lecture is going to be on this. For example, if you see, this is the front part of the cornea. Okay, when the light comes this way, it's refracted and goes directly right there. Right there. And that's called the macula. And this is where the whole vision takes place. So between the optic nerve right there, if I make a circle like this is where all the vision takes place. The peripheral retina has nothing to do with our vision, but it has to do a lot about medical problem. The cornea is right here. You see the iris, which is blue in here. And right behind it, there is a lens. It's like a lens in your glasses. And that lens is a natural lens which does the focusing for us. So remember this drawing. Okay, you need to know the cornea, the lens, the optic nerve, and the macula. That's all you need to know for that. I'm going to give you a different one, which is much less complicated and much better. Again, the cornea, the lens, the optic nerve, and the macula right there. So please remember, because I want to be referring to this all the time. First, we're going to be talking about the definition of the disease. You can read it as well as I can. And it is an impairment of health or a condition of abnormal functioning. That's what a definition of a disease is. Your body doesn't function normally. And I want to be talking mostly of dry eyes. We're all in a certain age where we do have dry eyes, and I will tell you what it is and how to fix it. Conjunctivitis, which is most commonly called pink eye. Cataract, which all going to go through, and I'm sure a few of you have had cataract surgeries. Glaucoma, which I do have myself, and I treat myself for glaucoma. Diabetic retinopathy. What does that mean? It means the diabetic, the problem you can have in the retina with diabetes. And now we'll discuss more when we get to that stage. Hypertensive retinopathy for people who have high blood pressure. Macular degeneration, and the acquired immunodeficiency syndrome, mostly called AIDS. Now I want you to remember one thing. I practiced for 50 years in California, and I used to tell my patient, I need to see you next year. But why? I'm okay, I'm fine. No, I need to see you next year. And the people come, and many others do not come every year for an eye examination. And the problem is, in the early stages of any of what I'm going to talk today, there are no symptoms, none whatsoever. You don't know. And I have picked up many, many people with hypertension, with diabetes, with macular degeneration. They did not know. So my suggestion to you, whatever you can pick up today out of this lecture, is make sure that you have your eyes examined on a yearly basis. There are wonderful doctors here in the village, and I can name a few of them if you need any reference. I want to talk mostly about, at the beginning, about refractive error. What does it mean, refractive error? There are people who never wear glasses, they're normal. When you reach a certain age, you have to wear glasses. And we're going to start first with emetropia. Emetropia is normal vision. And I'm going to point this to you right there. This is a schematic eye right there. The central ray goes right directly to the fovea, to the central vision, and the external ray, they just focus right there. So this is a normal eye. The people don't have to wear any glasses. The only thing they need to know is wear sunglasses to protect them from UV light and getting cataracts. The next one I want to talk is myopia. And I'm sure all of you know what myopia is. There are some myopic people in here. It is mostly commonly called nearsightedness, where the distance vision is blurry. So why do children, they do like this? If you look at my eyes, they do like this when they're in school. They squint because the central ray goes directly to the fovea, right there. So when they squint, they eliminate all these and they can see. But eventually they have to wear glasses because a myopic eye is an eye which is too long. When you saw the first picture, the light converged right there. So being too long, there is a big blur right there. And of course, glasses, contact lenses, or laser surgery will help for that. The next one we're going to go to is, and this is what a myopic sees, by the way. This is all blurry. When they put glasses, everything is very nice and clear. Next one I'm going to go is hyperopia. A normal eye, like I showed you earlier, is normal until we get the age of middle 40s, when you see people start doing this and they try to read. And hyperopia, by definition, is an eye too short. So the light focuses in the back of the eye and you have a big blur right there. But people who are very, very farsighted, the distance vision and the near vision is blurred. If you look at me, I take my glasses off, I cannot see you. I see a big blur, so I need to wear my glasses in order to see far, to see intermediate, and to see near. Again, how do you correct glasses, contact lenses, or laser surgery? Now, there's a lot of people, this is what farsighted sees. At near, they don't see very well, the intermediate vision is blurred, and the far vision is a little bit better. The next one is astigmatism, and you hear people coming and tell me, oh, I have stigmatism, and I tell them, no, it is not stigmatism, it is an astigmatism. What does it mean? It means that the cornea, again, the cornea, we come back in here, instead of refracting the light in one point, refract the light in many different points on the retina, and people see things blurry. Now, I'm sure you've seen artists, painters, very famous painters, and you see their painting and you see everything is crooked because that's the way they perceive it, and this is what's coming out of it. If we go, the astigmatism is a common, mild, and very treatable imperfection of the curvature of the cornea. Being a specialist on the cornea, my job was to straighten these corneas to make them normal. But again, what you do is glasses, contact lenses, laser surgery, and this is what you see, normal vision, and somebody with an astigmatism sees everything distorted. And that's what the painters look like, and that's what they represent what they paint. The next one is a presbyopia. As I told you earlier, when you reach the age of middle 40s and your arms are no longer long enough, then people go to the market and they buy those reading glasses, which is the worst thing to do, because not two eyes are equal. So when you buy reading glasses in the market, maybe one eye can see okay, the other doesn't. It's like if you're not wearing the proper shoes and you're wearing one with a high heel and the regular shoes and you're walking not comfortably. Now even him that you all know, the Captain Kirk on Star Trek, also has to wear glasses. And it is an age-related factor, glasses, contact lenses, and laser surgery also. And this is what usually people do, they keep doing this in order to be able to see clearly. I'm going to go now directly on the ocular disease, that's what you're here for. It was just a little introduction about why do we wear glasses. Ocular infection. I'm going to be talking about cataract, glaucoma, diabetes, hypertension, and macular degeneration. Dry eye syndrome. Don't we all have dry eyes? I'm sure all of you have it. What does dry eye mean? I had patients coming with red eye, with clear eyes, and they still have dry eyes. And when you have dry eyes, your eyes start profusely tearing. And when I diagnose a dry eye to patient, they tell me, but I'm tearing, how can I have dry eye? That is true. You're tearing because your cornea is dry and because of reaction, the brain sends in this message to the eye and you start tearing. But the tears that you have when you have dry eyes is not a real tear. So we're going to be talking about dry eye. What is it? It's a condition associated with inadequate tear production and marked by the redness of the conjunctiva. Other syndrome may include stringing, burning of the eye, and excess tearing, as I was telling you right now. Stringing discharge from the eye, pain and redness. A lot of people with dry eye experience heaviness of the eyelid, and sometimes they even fall asleep because it's so heavy and it's very painful. And also the loss of vision is very uncommon unless we develop any problem with the cornea, because the dry cornea start to desiccate and start to slough off and it becomes a real problem. How do we treat dry eye? First, to determine the reason of the dry eye. We look at the patient, we talk to them, we get a head story, we look at them on a microscope, and then there's a medication actually which works quite well for patients with dry eye. It's called Restasis. I don't like to prescribe Restasis because it's an addiction to antibiotics. I never give it, very, very rarely. I treat dry eye with this problem right here. It's called a punctal plug, and I want to tell you about it in a few minutes. Lubricating drops, you can use any lubricating drop you can buy in the pharmacy. You can use it 2, 3, 4, 5 times, as many times as you need, but it doesn't cure the dry eye. The warm compress associated with lid scrubbing helps. If you look at this picture right here, right at the edge of the lid margin, we have 21 glands, which goes up like this, like a deflated balloon. And also we have 21 glands going this way. Now this gland produces a special oil. So when you blink and the outer lid touches the lower lid, it triggers some oil which covers the eye and retard the evaporation of the water of the tears. When you have this gland plugged, and this is a very common in women because the women use makeup and they put this black makeup right around the eye and they plug those glands. So there's a treatment for this, which kind of long treatment, I don't want to go over it, but it is treatable. And I treated this mostly with this lid scrubbing without having to use antibiotics. Now the next one is called a punctal plug. If you look at very clearly and closely, there is a hole right there at the end of the lid, and there is a hole right there. It's called a puncta. Now the extreme, the last resort that I use in here is to put a plug, a silicone plug. We stick a silicone plug right there and a silicone plug right there. Why is that? Because when somebody have excessive tears, the tears go down this way through the nose, and I'm sure you all experience when you cry, you blow your nose all the time because all the tears go in your nose and behind your throat. So by putting these punctal plugs right there, you kind of keeping a little reservoir of tears right there, and every time you blink, you're lubricating your eye. When I met my wife many years ago, she told me that she was suffering of dry eye and nobody could do anything. So the first thing I did on her, I put some plugs. That was over 20 years ago. She still had the same plug and she's ready to tell you it works quite well. Dry eye, we're going to go to bacterial conjunctivitis, which is a pink eye, mostly commonly called pink eye. Okay, again, you can all read the same thing there. It's an inflammation of the cornea. It is the most common eye disease in the Western Hemisphere. The conjunctiva is a membrane covering the eyeball and the inside of the eyelid. So when that got inflamed or infected, it created a big problem. So you can have conjunctivitis from bacteria, from viral, and from fungal. You can have like using some chemical in the eye, you're splashing some chemical, like cleaning product, for example, you're cleaning and you splash it in your eyes. First thing you do is immediately to rinse it with a lot of water in order to eliminate that pigment. Or a physical irritation, which is mostly related to contact lenses. A lot of people are wearing contact lenses and they don't realize that eventually at the long run you're getting infection in the cornea. And this is a case of bacterial conjunctivitis. And you can see this is all red, very wet, with a little purulent discharge right there. The eyelid is swollen, very swollen, and those glands right there, and I talked to you before, it's called meibomian gland, are plugged. It is usually unilateral. In other words, it happens only in one eye and not the other. But if the patient takes a tissue and wipe off these and then put it on the other eye, you definitely can get it because it's extremely contagious. Cats, dogs also at conjunctivitis. And you can see your own pets, one of the eyes in the close or red. In my dog, I use human antibiotic drops. I just put one drop in her eye and the next day it's all clear because it's quite powerful. But if you take these animals to the vet, that's what it's going to give you, just antibiotic drops to clear them up. Now we're going to talk about this bacterial infection. I'm going to give you some pictures to look at it. This is called a blepharitis, and I'm sure everybody has seen right at the base of the eyelashes, you've got some bacterial nest. And I don't know if you have seen this, but a lot of kids catch it at school. And what they do is they just take it and in their fingers and they throw it away. This is not contagious. It's called a blepharitis, and it's treated with hot compress. You scrape with baby shampoo and antibiotics drop, and within 5-6 days it goes away. If it doesn't go away, we give some steroid in order to clear the inflammation. But this is quite very common. Also, if you look at yourself or look around, a lot of people have this lid margin right there, very, very red. And they don't know that they do have blepharitis because this is obvious, those bacterial nests, but they have a little tiny one that you don't see with the naked eye. And those people, when they have the lid margin very red, all the way around, go to the doctor and get yourself some treatment, because what it does, eventually, in the long run, you lose your eyelashes completely, and then they do not come back. And this is cases of bacterial infection. You see this in baby, a lot of discharge. Okay, you sticky eyelid, redness. Photophobia means problem with the light. If you have a bacterial infection and you go outside, you cannot see the light. It's very, very painful. It's extremely contagious. And you treat again with hot compress and antibiotics for 8 days. I give medication to a patient, 3 days later they call me and say, oh, everything is clear, everything is fine. And they quit the medication. And I tell them, do the medication for 8 days. It takes about 8 days to kill the bacteria in the eye. They don't. They come back a week later with again the eye inflamed and start the medication again. And this is what you can see. Now we're going to go to the viral. The virus in the eye. Again, one of the gland in it got plugged. The virus got inside the gland, and it becomes extremely swollen, most commonly called stye. And it's very, very painful to touch. Again, treatment is just hot compress and try to put pressure on this in order to release and open the plug. And this is also a case of a fungal, of a viral conjunctivitis right there. Okay, viral conjunctivitis, or pink eye, most commonly called self-limited condition. Normally, we don't give any medication for this. Normally, it takes about 10 to 12 days to clear up. If it doesn't clear up, then we do cold compress and a lubricant and artificial tears. But no medication, because the virus doesn't respond to medication. A lot of people, again, they go to the pharmacist and with red eye like this, and they give them antibiotic drops. It doesn't work. So it needs to be determined if it's viral or bacterial or fungal. We're going to go now to, again, another case of viral. It is unilateral. It is red. It is tearing. And sometimes it's very painful. Again, cold compress and lubricating drops. No medication. And we're going to go now to the fungal one. Fungal. Okay, the fungal one can be extremely dangerous because people are working in a garden, they bend down, and they get poked in the eye by a plant. And that happened to everybody. And the eye becomes extremely swollen, very painful, and it can be dangerous because sometimes the fungus get into the cornea becomes extremely opaque and is very difficult to clear. I have seen patients losing vision totally because the cornea become totally white. So it can be very dangerous. If you get poked doing your gardening, and either in the white part of the eye, okay, or on the cornea itself, run to the doctor immediately in order to get this antifungal agent. Sometimes, in an extreme cases, like when the cornea becomes extremely white and opaque in here, we can give some steroid, but we do usually treat the fungals without steroid. Okay, this is the one I was telling you. It's called the fungal keratitis, right there. The cornea becomes extremely opaque, and sometimes the eye has to be enucleated also. So this is a serious problem. Just remember, if you get poked in the eye by a plant or by a tree or by a branch, go to your doctor immediately. Okay? With potentially catastrophic visual result, I'm sure you can all read this. What you get is blurred vision, redness, tearing, photophobia again, which means problem with the light. You have pain and you feel like you have a foreign body in the eye. When you blink, you feel there's something there. It's because the cornea is no longer round and no longer very highly polished. It is keratitis. It's full of problem right there. The management consists of medical therapy with topical and systemic antifungal medication in combination with steroid. Not always. Now, if you look at, I will dig in here to show you the conjunctivitis on the bacterial, the viral, the allergic, the bacterial involvement, bilateral. On the bacterial, as I said to you, it's 50%, 25% in virus, and mostly in allergic. Okay? When you have an allergic reaction, usually it's both eyes. When a patient comes to the office with the right eye, and if we do see only one eye is red and one is normal, we know already it's not an allergic reaction. The discharge, you have the mucopurulent discharge, which means there's a lot of pus coming out. The viral, you got the watery, as I told you earlier, and in the allergy, there's nothing. It's just very red, and when you blink, it's very gritty, like sandy feeling in the eye. The redness, yes. Pruritus means itching. So, is it itching on the bacteria? No. Non-viral, but yes, on the allergy, the eye is extremely itching and people are rubbing the eye continuously. Now, the most important is, and this is mostly secondary to contact lenses. A lot of people are wearing contact lenses, either hard or soft lenses. We see corneal ulcers and soft contact lenses most likely, because people do not clean their lenses. Or if they have a problem with the eye, they take the lens, they spit on it, and they put it back on. I've seen this many times. People have done that. You see people losing contact lenses, they take it from the floor and they put it back on in the eye. It's just bringing different bacteria and different in the eye. So it's quite very dangerous. And I want to give you a few corneal ulcers to tell you which one is dangerous and which one is not. There is a corneal ulcer, for example, which I'm going to talk in a few minutes. If it's in the center of the eye, right dead center, you lose the vision. And if it's not treated within 72 hours, we have to enucleate in the eye. So contact lenses are also dangerous little things. Okay, it's an open store on the cornea. You can read it. Here, the cornea covers the iris, the color part of the eye, and the round pupil. Also, when you have a corneal ulcer, the pupil can change shape. The pupil usually points toward the ulcer. In other words, if you have an ulcer right, let's say at a 6 o'clock position, you look at the pupil is round on top and like a teardrop. So we know there is a problem right there. The treatment must be immediate with heavy doses of antibiotic. I used to treat my patient by giving them a very strong antibiotic, and putting a drop in the eye every half hour for the first 6 hours. Then every hour for 24 hours. And then see the patient 24 hours later to make sure that this little buggy, right, that little ulcer is starting to disappear. If it's not, then we need to give even stronger antibiotics, but most of the time the treatment is quite good. Now, I've told you about different ulcers. This one right here is not dangerous. It can be treated with the treatment I just gave you, and in 5 days it's all cleared up. This one is much nastier because it's in the center of the cornea, which means it blocks the pupil. And when you block the pupil, the light doesn't go through. But it is treatable, the same treatment that we give to this one, with heavy antibiotic drop. This one is a nasty one, because this one, when it's the center of the cornea, there's a medical term for that, and if the patient does not go see a doctor, within 72 hours, we have to enucleate the eye because the bug goes inside the eye and goes to the optic nerves. And the optic nerve is very short. It goes directly from the back of the eye to the back of the brain, which is about this dimension. So it can go to the back of the brain and quite dangerous to the brain. That's corneal ulcer. Now we're going to go to the allergic conjunctivitis, which is the most common one, and you can see it quite often in here among the population. Now, there's an increased amount of tears, very, very much. The eye is extremely itchy. You can have the blurred vision, you can have swelling of the eyelid, and the treatment again is an antihistamine drops or decongestion drops. People go to the thing and they buy, I forgot the name of the drop. Any remember the name of the drop? Huh? No. The name will come back to me. That's the one very, very commonly advertised on television. That's the worst drug that you can put in your eyes. Because what it does is, it constricts the blood vessels. Because when you get an allergic conjunctivitis, the blood vessels are very open and they're very wide, and that's why you see the eye becoming red. So they put this, I'm trying to blank on this. Visine, thank you very much. Yeah, Visine. And what this Visine has is the component which constricts the blood vessels, which means pushes the blood away and the eye clears up. But what they don't tell you is within a few hours, the blood vessels come back even bigger. So it's redder, and you keep on putting these drops and drop, and it becomes an addiction, but it's not a good drop. If it is persistent and it doesn't clear up with these antihistamine, then we do some steroid drops and we clear up the inflammation immediately. So far for the conjunctivitis. We're going to go now to the real ocular disease, and we're going to start with the cataract. Now I want you to look at this cataract. What is cataract? A lot of people come to me and say, you know, I have a cataract, I see a little skin growing over the eye. That is not what a cataract is. Remember the drawing again that I showed you earlier, and I told you there is a natural lens? That natural lens becomes opaque with age. And everybody at a certain age will get cataract. And there are, of course, different types of cataract, but I'm going to be very global and give you just an idea. Okay, it's a clouding of the internal lens of the eye, and when the light comes in, it has to go through that opacity, and of course it is very difficult to see because if it's at center. So most cases it's in older people, but I have seen patients in the 30s and the 40s, which we had to have cataract surgery in order to clear up the problem. Now I want you to look at this. This is a cataract that you can see on the microscope, and it's right in the center. Now when the pupil, when you go out in the light, automatically the reaction is the pupil becomes very small. Okay, like this. And when the pupil is small, what happens? The light doesn't go through. It's impossible. so they cannot see clear. So people with cataract surgery, the first thing we ask them, can you see better at night than during the day? Oh yeah. Why? Because the pupil at night gets bigger and the light can penetrate around this opacity and they can see a little bit better. What do we do for this case? We put a lens implant. So the surgeon opens up a very tiny opening in about 2 millimeters right there at the 12 o'clock position, right where the white gets to the cornea, and then insert any of these implants. And there are different implants. There are the one multifocal implant, there's a one only near vision implant, or an implant just far away. I have patients who ask me what kind of implant I should have, and I tell them, what kind of work do you do? So I'm going to give you just an example of my youngest brother. He's a dentist, and he's always bending down looking at his patient. So he said to me, I'm going to have cataract surgery, what would you suggest? I said, put monofocal lenses. In other words, do not put a multifocal lens. And he said, why not? Because with the focal lens, I'm going to be able to see near and distance-wise. I said, no, you're not. The multifocal lens will not give you good vision at near. So depending on your profession, you have very good vision at distance when you put the monofocal lens and just put regular reading glasses. But there are a lot of people who would rather be blurred in here, be blurred there, be blurred there. That's their choice. But when you see, you say, oh, I have an implant, that's exactly the way the implant looks. This implant, or this one, or that one, they all have the same configuration. They fold it. So when we introduce them inside, instead of the natural lens of the eye, we remove the natural lens, we put an implant there, and it unfolds automatically, and then we put it in position and the patient can see quite well. Now remember what I was telling you about the lens right there? And that's the lens which is removed. In a good cataract surgery, this part is the one which becomes opaque. The centers become opaque, and most of the time the back capsule right there does not get opaque. So many surgeons, doesn't work? Oh, not anymore. I'm sorry, it doesn't work anymore. But anyhow, the back capsule, no more battery here. Anyhow, the back capsule is left in place and we put the implant right against the back capsule and the patient sees quite well. But one thing I want to point out, I'm going to try with my finger. And I put this picture purposely where you can see on the bottom, if you can read fovea right there, and you have the optic nerve on this side. Now if anybody has any problem with the fovea and with the optic nerve, cataract surgery is not going to do anything. Because remember what I told you, the vision is going to take place right in the middle of the fovea. So anybody who has macular degeneration, for example, who has diabetic retinopathy or hypertensive retinopathy, and they have a lot of hemorrhages right at the dead center on the macula, cataract surgery is a waste. And these are different cataracts. The one up on the left is what we call a mature cataract. The one on the right, you can see 11 o'clock, 12 o'clock, there is no opacity, it's just a small cataract. This young lady here had a congenital cataract, and she had a white eye all her life until we put the contact lenses to match the other eye, and she looks much better. And there is another cataract on the right, which goes from 1 o'clock to 5 o'clock. So it's just an opacity of the lens. Now we're going to glaucoma. Glaucoma is a very serious problem. Most of the people don't know that they have glaucoma, and they don't know that their pressure is high. There is absolutely no symptoms in glaucoma. You can have glaucoma for many years, you can have a very high pressure in the eye, and you don't know it. Glaucoma is mainly in the optic nerve, and you can see this big white there on the optic nerve. I mean, the optic nerve has been completely damaged, and the optic nerve is no longer responsive, so you have no more vision. Glaucoma is the increased pressure in the eye, and you have to have it done at least once a year. Your ophthalmologist will take your pressure and tell you, you're okay, your pressure is good. Glaucoma is damage to the optic nerve, and we have a different treatment. Most of the time the treatment is drops. People use drop in the morning, you can use drops at night in order to lower the pressure and keep it. And early diagnosis in glaucoma is very important because people lose vision to glaucoma, they start losing what we call the peripheral vision. The central vision is the last one to go. So you see people, they don't know that they don't see right there. There's a very simple test to do is you cover one eye, like this, and then you hold your finger right there, but you look straight, okay? And if you can see your finger, that means you're okay. It's called the peripheral vision. And I'm going to come to this right now. So you see the optic nerve in these two cases. On the left one, it's not an advanced glaucoma yet, but there is glaucoma, and you can see that optic nerve becomes white, and the blood vessels are pushed to the side. And on the right eye, that's an advanced glaucoma. So a lot of patients tell me, many years ago, before the internet came into play, they will tell me, what do you see when you dilate my pupil? What do you see inside the eye? Well, this is exactly what we're looking at. Glaucoma, the treatment, eye drop to lower the pressure and to monitor what I just told you, the visual field. So if you do what I want to do right here, cover one eye, you look straight out of you and you look at your finger like this. And if you can see the finger as you go in different direction, that means your visual field is still okay. But nevertheless, the glaucoma needs to be treated every 4 months to 6 months and do what we call a visual field, which you have on the bottom. The top left is a little bit damages, and then as you go from left to right, the damages become bigger and bigger and bigger to the point on the bottom right, this is a totally blind eye. And it takes about 30, 40 years to lose vision secondary to glaucoma. But nevertheless, every time you go to the eye doctor, make sure that they do the glaucoma test on you. And also having your pupils dilated. Diabetic retinopathy, I'm going a bit fast because I have not too much time. Diabetic retinopathy is one of the leading causes of blindness in the United States. It's extremely, very, very important. People do not know they're diabetic. They reach the 40s, the 50s, the 60s, and they still don't know they are diabetic. But when you go to the doctor and they dilate the pupil, okay, and I'm going to show you, before I go to the next point, the photocoagulation is a treatment for diabetes beside monitoring the sugar level. Okay, this is what I just said. Now this is diabetes, okay? When you look at inside the eye, I'm sorry I don't have the pointer anymore. Oh, there we go. Okay, this is the optic nerve. This is a lens again, this is a cornea. And what we look at mostly in diabetes is those white spots, all these white spots they call drusens, and they start with the peripheral retina and then they move to the macula. Now the macula is right here, and this is the optic nerve, and you see this is pretty damaged. There's a lot of damages right there, but if you look at the central vision right there, the patient has still 20/20 vision. You can have the eye full of blood. As long as this right there, the macula is good, you still have good vision. And people having good vision, I see well, why should I go see a doctor? Why spend money? That is not true. You need to have your pupils dilated on a regular basis. Make sure that the doctor is looking at your entire retina. I'm going to give you more picture of it. Okay, the initial stages, the patient, there's no symptom. They start having symptom only and only when the macula is damaged by this thing. This is a rendering of all the retina. This is what we see. The macula is ready and all the blood vessels are. How do we start with diabetes? Is first you see those white spots right there on the macula, which could create also on top of the diabetes a macular degeneration. And then you see these little round dot hemorrhages. We call them microaneurysms. They're very, very tiny. And you have to have your eyes dilated for that. I went to California last year. I went to my old office and I saw the doctor who took over my practice. I said, dilate my pupils, I want to look at something. Dilate my pupils, we took pictures, and I saw that right at the edge, or completely at the edge of my retina, I had a hemorrhage right there. It was very scary, but it's not on the macula, it's not on the optic nerve, so I'm monitoring it just by having the pupils dilated and take a look at it. Now, eventually, those small hemorrhages are being reabsorbed in the body and they disappear. The bigger one are the one who stays there. Okay, the microaneurysm I was telling you, this is an early sign of diabetic retinopathy. We see those little tiny round dot hemorrhages. And how do we treat these? We treat them with a laser. Either we just monitor them and have the patient come back every 3 months and look at them again and compare photo to photo, or we can just zap them with a laser and coagulate them in the foot not to become bigger. Okay? The dot and blood hemorrhages, and then you have the flame-shaped hemorrhage. I will show you one of them. And the edema in the heart exudate, this one, the white dot I showed you earlier. And this is what we're looking at right there. See, you have this one there, that one there. The optic nerve looks very good. The macula is good. This patient sees quite well. On this side, this is a macula, and having a lot of this hard exudate. If this moves toward the macula, the patient loses the vision completely. And the problem is, you don't know. And there are absolutely no sign. The reason for me to give this talk today is for you to be aware that to go to your eye doctor and have your eyes examined, have your eyes dilated, just to make sure that you don't have any of these problems. Because that's what creates the biggest problem. We're going to go now to the hypertensive retinopathy, which is very similar to diabetes. And as you can see, this hypertensive retinopathy happens mostly in the optic nerve where you have flame-shaped hemorrhages. And we can see them and determine that those are hypertensive and not diabetes. They also have the same exudate, same hemorrhages, but we know by the shape of the exudate and the shape of the hemorrhages we can differentiate diagnosis from diabetes, and of course doing a history on the patient. This one doesn't want to change. Here we go. Okay, you can read this. Patients who have hypertensive retinopathy have been hypertensive for many years. Of course, we can treat hypertension by taking medication, by having a diet, by being healthy, but nevertheless, if you have hypertension for many years, again, my suggestion is to go to the eye doctor and have your eyes dilated in order to make sure that you don't have any of those hemorrhages. You have read this? Okay. The result, okay, high blood pressure. Okay, you read it, this is what I just told you in a few minutes ago. The higher the blood pressure, the longer it's been high, the more severe the damage in the eye will be. Okay, and this is what you see in hypertensive retinopathy. You see that the hemorrhages are different than the one that you have in diabetes retinopathy, because in diabetic, you have round dot hemorrhages. In hypertension, they're not round. They're little, not really round, and they flame shape. This guy here, where the macula is right here, the dark spot is always the macula. The vision takes place exactly right around there. See? And if I do this circle, there's nothing there. There's no glaucoma, there's no macular degeneration, so this patient can have hemorrhages everywhere, still can see well. And most of the people say, well, I can see well, my vision is good, I can see well, I don't need to go see a doctor. That is wrong. Again, another kind of picture, I think I showed them to you earlier before. And again, another picture of it, and you can see, this is what I call the cherry red dot, which is normal. You see those exudates right there. Eventually, these exudates are going to move with the time, and they're going to be right on the macula. This patient will lose their vision. You can see the hemorrhages right there. And the flame-shaped hemorrhages. Again, that's another red ring. This is macular degeneration, which is the most important when we become older. The macula, as I explained to you again, and I will repeat it, is what gives us a 20/20 vision. I'm going to give you a little test. You're going to all do the same test in a few minutes, okay? And this is what you see in macular degeneration. Right in the macula, there's a lot of changes. For example, this guy right there is totally blind, has no more vision. He lost the vision because the pigmentation comes into the macula. It's finished, it's gone. This guy has some macular degeneration, no glaucoma, just the macula is involved, and there are different kind of macular degeneration. Okay, it's caused by the deterioration of the central portion of the retina. Few people are aware of the macular inner. Okay, I'm giving you a statistic. This you can read it. It's not so important. Okay, now, when I used to see patients and I see the first drusens, which is those exudate what is around the macula, I will give them immediately this treatment. There was a research done in England many years ago, and they found out that by giving this vitamin C, exactly the amount of milligram, vitamin E, lutein, xanthan, zinc oxide, and copper, exactly what you see right there, the macular degeneration stops from growing. So I have treated many patients where I will see them 6 months a year, and then a year later in a year, and we take pictures, and we can compare the pictures one after the other, year after year. If they do this treatment continuously, they're nothing but vitamins. It will arrest the progression of the macular degeneration. Now, if you use laser, if you go to your doctor and you see a macular degeneration and you want to do laser and zap you with the laser, if the lesions are on the macula or near the macula, do not allow them to do it. Because every time you zap with the laser, you leave a scar. And that scar is bigger than the little exudate and goes on the macula, and you can lose your vision. Now, if you have hemorrhage all around in the peripheral vision or in the macular degeneration, it's all around and far away than the macula, the laser will be the treatment. Because you zap them with a laser and you stop the progression of them. Now, this is the, I told you so many exudates right there, but the macula is still very good. So this person sees okay. And this is a rendering of the macula being right there. This is somebody you see normal. This is what you see with the macular degeneration. Now I want to ask you to do something. I want you all to cover your left eye. And you look straight ahead of you, and you hold your thumb. And you bring your thumb closer and closer to the eye. What do you see? You can see only around your thumb, right? You don't see through the thumb. That's macular degeneration. Your central vision goes, and you can see all the way around. So people with macular degeneration learn, instead of looking straight directly to the person, they look to the side. And they learn to use around the macula to see clear. So it is a problem. And again, I can emphasize very, very strongly tell you, go to the doctor and be examined on a regular basis, because if it's taken all time, you can do it. Now, that's it.
Hi. We're going to keep going for a little bit. Obviously, this is a fascinating topic.
I'm almost done.
And he's almost done. But for those of you that need to leave at this point, just if you'll quietly leave, we thank you for being here. The rest of you stay, and we'll let him finish, and then we'll take questions.
I'm going to talk about retinal detachment. This is very rare. It happens mostly to very high nearsighted people, because as I showed you at the beginning, nearsighted people, it's an elongated eye. So the eye being so elongated, it pulled on the retina, and a very high nearsighted, the more is nearsighted, the longer the eye, it breaks the retina, and this is what you get when we look at inside here, right there. This is breaks in the retina. If it's the retinal detachment is on the peripheral, you don't lose the vision, but if on top and the retina falls down, you lose your vision, but it is very treatable with a laser retina. Okay, this is all the symptoms you have of retinal detachment. Okay, you have the flashes of light, which is the most important. You have also, I tell my patient, if you see a lot of, like snow falling in front of your eye, all the snow, you have a retinal detachment, you come in immediately. You have a lot of floaters, you see like hair floating around you. The symptoms are very characteristic. So people who know the symptom, they go directly to the doctor and they be dilated and zap it back with a laser. And the last one is the 8 syndrome. The people who get these 8, we have totally messed up retina, completely messed up. So the people who suffer of AIDS, and the first thing that goes in the 8 people are the eye, is the retina. Immediately the vision goes away. And that's what they cannot fight infection because they don't have any immune system anymore, and the retina gets full of blood more and more and more. And I've been an eye doctor, and I've seen so many people losing the vision and dying eventually. And this is an autoimmune system, and it is transmitted mostly by sex, mostly with needles, and the treatment is very complicated and dependent on the severity of the disease. But it took an enormous amount of antibiotics in order to fight the infection, in order not to lose the vision. Unfortunately, when I put this there, the picture, you see the eye turning around. And it keeps whirling around. This one doesn't do it, I don't know why, but thank you very much. And we're open for questions.
Please come up to the mics. There's one on this side, and there's one on the other side. Thank you.
First of all, I really enjoyed that presentation. Thank you very much. Can't hear? I have 2 questions, if you might indulge me. The first one concerns conjunctivitis. Clinically, you can differentiate bacterial from viral, usually because the bacterial tends to be quite virulent. But how about fungal conjunctivitis? Is that a clinical diagnosis, or do you do a swab? And the second part of that is what sort of drug
That is correct. You can swab it and do a culture on it. But most of the time, a doctor who is very well trained can differentiate between the 3 of them, just by the history.
What would be the commonest fungus, and what would be the treatment? What sort of fungal drug would you use?
The fungal?
Yes.
They are special medication, antifungal medication. And we try to use it, just the antifungal, not to use steroids. Because people are using steroid in the eye for a long period of years, and they get fungal conjunctivitis secondary to the steroid. So we try to stay away from the steroid.
Do you have a brand name of a fungal drop?
You know, I've been practicing for 4 years, I forgot. I'm sorry.
Anyway, my
Yeah,
second...
there are names. If you want, if you give me your email, I'll send you a list of them. I'll be happy to do so. I didn't want to put any medication there because I didn't think that anybody would be interested to know medications. Yeah, but there are some.
My second question concerns macular degeneration. My father developed that in the 70s, and back then they were developing at the University of Waterloo in Canada an apparatus that was sort of like a virtual reality gadget that you wore. And at the same time, I think they were also in Florida, they were developing some kind of a computer chip that you could actually implant in the retina. Can you give us some updates as to what state of the art is now?
Macular degeneration, you have two of them. One is called the dry, and then one is called the wet. The wet macular degeneration is when the patient retains water on the macula, and that's the one which goes extremely fast. If the patient is not treated immediately, they can't lose the vision. The dry macular degeneration is a very slow growing one, extremely slow, it takes a long time. They have done many research about putting an implant in the back of the eye. It's still up to date as far as I know, and I'm trying to keep informed. There is really no cure for macular degeneration. Once you have it, you just have to live with it. There's also some injection they put inside the eye. There's an injection, a special medication injected, which slows down the progression of the macular degeneration. But again, it just takes time. I know my father had macular degeneration wet, kept calling me from Canada to the States, do something. I said, there's nothing I can do. And he died blind. Because there's not too much, there's nothing really on the market right now to cure macular degeneration. I'm sorry.
My question to you is, what is your opinion of taking an eye vitamin like Ocuvite?
That's good too. That is a good vitamin to use.
Also, a side comment, our daughter teaches at the University of Southern California. She is an optometrist.
Oh, good.
So I want to talk to you later on.
Okay, no problem.
I have the occasional time when I have in the corner of my eyes the appearance of water running over crystals. Out of the corner of my eyes, I see water running over crystal. This kind of appearance. Is that good?
You see like ink floating?
Yeah, right.
Those are called floaters. And floaters is the inside of the eye. The front part of the eye, right behind the cornea, we have aqueous, humor aqueous, it's a liquid. And behind the lens, which fills out the whole entire cavity, it's called the vitreous. With age, the vitreous becomes liquefied. As we're young, it's like a jello. If you take the jello and you leave it out for 2 or 3 days, it becomes liquefied. That's why I try to explain to the patient, you shake it like this and it breaks down. So people who have floaters, as long as the floater stays in one place, and as long as it's not moving, and as long as you don't have light flashes, you're okay. It just has to be diagnosed by the doctor, by not any people looking at it. Because floaters, when they attach to the retina in the back, and they move a lot, they pull the retina, and you can have a retinal problem.
So must be getting old.
So no light flashes, you're okay.
Thank you.
Thank you. It's been a great talk. You mentioned that you could recommend some doctors locally that could help with dry eye syndrome, maybe to do the plugs that you talked about. Can you give us the names of
Yes. His name, I took my wife myself to him because I found him to be one of the best ophthalmologists here in the village. His name is Rigoberto Reyes in his Plaza Montaña. I have referred to him many patients, and I have taken myself friends, and I will need them. He's very, very well equipped. He has all the equipment necessary to diagnose any problem, ophthalmological problem. He's a very good doctor. You can mention my name. He knows me under Dr. Gabriel, so he will take care of you.
Thank you. The name again?
Rigoberto Reyes, R-E-Y-E-S. And he's in the Plaza Montaña. You can see his sign right there.
Hello. Is it safe to have cataract surgery here in Baha'i? And where would you go if you were me?
I will go to Dr. Reyes. Absolutely. He's a wonderful doctor, and I was, when I took my wife to him, because when we came back from California a year ago, and I used to dilate her pupils every 6 months because she's diabetic. And I want to make sure that there is no hemorrhages. And I hadn't done it for years since we've been here. I went to see Dr. Rigoberto, and I didn't say anything to him. I didn't say who I was, what kind of a doctor. He examined me, and I took my whole entire file on her. And the way he examined her, I was looking at myself examining patients, so I felt extremely comfortable. When he put her pupils to dilate, then I showed him the record, and he said, "Are you a doctor?" I said, "Yes." And he felt more comfortable with me. We went through every single picture that I have on her, and he took pictures, and we compared the picture from the first time that I took a picture on her to 20 years later. When he saw her, there was absolutely no change. And I want to keep it this way because that's what I'm saying to you. Being followed with pictures, you can compare pictures, not notes. If I write on my file, no hemorrhages, okay? But next year I will see the patient and I say no hemorrhage where? So when you take a fundus picture, you can compare picture to picture to picture, and you can see the evolution of cataract or glaucoma or any ophthalmological problem. So it's good to have it done. And I will go to him to have the surgery done. Definitely I will.
The second part
And I
is,
do have cataracts too.
how long do you need to stay in recovery before you can fly away? 1 day.
You have surgery and you go back home.
Okay.
It's a 25-minute, 15, 20-minute surgery. It's an outpatient surgery, yes.
Yes, I used to wear glasses before. Oh, sorry. I used to wear glasses before, and I went through a LASIK surgery. That was many years ago. What's the statistics on LASIK surgeries situations such as, I mean, I'm seeing fine now.
So you had LASIK done on you?
Pardon me?
Yeah, you had LASIK surgery done on you?
Yes.
How many years ago?
About 15 years ago.
And you're still okay?
Yes, I feel
You had a good surgeon?
okay, yes.
It all depends on the surgeon. It all depends. In California, many years ago, we saw so many advertisements that you can have a laser surgery for $300, and you go to the doctor and he will charge you $4,000. And you wonder why is there so much difference in prices? It just depends on the surgeon, depends on the experience of the surgeon, depends what kind of surgery. It depends on many different factors.
Vision, welders, welders, they're like welding metals and stuff like that. How does this affect them, the vision of welding? How they become affected? Do they affect their vision as they continue welding?
It does affect the vision a little bit by after image, but you have to wear a shield in order to protect you from it. But when they do that, it's an intense light, yes, definitely. And if you close your eyes, you can see the light. It's called an after image. But this eventually goes away. There's no really danger for the vision. You can.
We're going to just do 2 more questions, and then for those of you who aren't going to get a chance to ask, Dr. Dery will be here, and he'll take your questions, and you can talk to him.
I have a further question about lens implants. 15 years ago, I had lens implants because of cataracts. They made major improvements in the lens implant itself. Is it practical to take it
a very good question. I've been asked this question many times in many years. The people who had lens implant many years ago, it was just a very rudimentary design. The lenses are much more designed and better perfection and better optics. Ma'am, if you do not have any problem and you're happy and your eyes is clear and your vision is good, don't touch it. Just leave it the way it is. We remove the lens only if there's an infection or if there's a problem, or if the lens has moved, it's displaced by itself, then we remove the lens and we put a new one. But if you don't touch it. You're welcome.
I just have a very general question. When do you need an ophthalmologist versus an optometrist?
Optometrists are very well trained doctors. The first 4 years of optometry school and the first 4 years of medical school is the same. Same classes, same everything. The only difference there is when a medical school graduate, they go into internship, then they go to residency and choose the one that they want to do. The optometrists go to a different kind of residency, which is more into children vision or contact lens vision, or they become specialists in that specific field. But nowadays, in the States, the optometrists, they call optometrist physician. They're allowed to do laser, they're allowed to do minor surgery, they're allowed to do a lot of things that ophthalmology are doing. And eventually, in my opinion, within the next 10, 20 years, there will be no optometrist, no ophthalmologist, there will be one eye doctor only. Because one is the same thing as the other.
Thank you so much, everybody. Thank you, Dr.
My pleasure. Thank you for listening.
So you all who are still hanging in here, thank you so much for coming. Turn on your cell phones. We look forward to seeing you